Hi everyone, my name is Louseioriana, and I currently work as an SUDPT at CMAR Community Health Centers. And the population that I currently work with is adolescent male in Washington State. Because of the population I currently serve and the stories, experiences I've been able to learn within my 3 years working as a counselor, I chose to focus on WAC 182 533 0701. Working with the youth struggling with drug and alcohol addiction has really opened my eyes to the reality of substance abuse and the very common causes of it. And I just really wanted to highlight a policy that could potentially help with reducing the probability of parents struggling with abuse passing it down to their children. So, as I move forward with my presentation, we will cover the purpose of the policy, the structure, benefits, and vulnerabilities, as well as how it impacts the therapist, etc. So, introducing WAC 182 533 0701, the policy states that substance using pregnant people, also known as SUPP, program provides immediate access to medical care in a hospital setting to substance using or substance dependent pregnant people and their fetuses. The purpose of the immediate access to medical care is to reduce harm and improve birth outcomes for birthing parents and their fetuses by preventing obstetric and prenatal complications related to substance use disorder. So, the SUPP program is an inpatient treatment program that lasts up to 26 days. It's hospital-based program for adults or adolescent individuals who are pregnant, have a medical necessity, have a history of substance use, and are declared at risk, have a provider one service card, or have a pending application for one. Services can include withdrawal management, medical stabilization, treatment, substance use disorder treatment. And the purpose is to one, reduce harm to a birthing parent and the unborn baby who needs stabilization for complications presented in substance dependent pregnant individuals. And two, to provide services to improve the health of the pregnant individual and the unborn baby in a controlled environment. At this point, you might be wondering why this policy matters. And based on whether you believe in a more punitive approach versus the restorative approach, I want to provide you some facts to help you understand why providing this type of treatment for those in need is important. So, for starters, 4 of every 100 infants with Apple Health coverage were diagnosed with prenatal exposure to alcohol or drugs. Okay. 42% of mothers to infants with potential PSE received any SUD treatment in the first 2 years of the infant's life. Infants exposed to substances prenatally were involved with state services and systems at higher rates than other infants with Apple Health coverage. So, by implementing this type of treatment, we can help with reducing those statistics and developing more healthy communities so that we are having less children being exposed to drugs and alcohol prematurely, and reducing any medical complications that might exist because of that exposure. Okay, now let's talk about some strengths and weaknesses that exist within this policy. On the strength side, the biggest strength is the removal of wait lists. For non pregnant clients, finding an SUD bed can take weeks. Speaking from experience, we have clients who are waiting months out to get a bed date, and depending on things that could be extended. And we don't know if our clients can afford that. So, with immediate access, it helps with getting those who need it in as quickly as possible. Under this policy, the goal is immediate access. Yes. This allows us to strike while the window of willingness is open for the client, as pregnancy, knowing that they are carrying a baby, a vulnerable individual, often helps those struggling with substances kind of gain a moment of clarity and understanding that things need to change. It stems from a harm reduction focus, as we don't want to place blame, judgment, anything that's going to keep that person from engaging in services that will be helpful for not only them but the fetus. Integrated care is implemented as you are in a hospital setting. You have access to specialists, medical specialists, behavioral health specialists, everybody that needs to be there in order to effectively care for the client and the fetus. And of course, preventative impact. I think the better, the earlier that we can get somebody in services, the better, and hopefully encourage them to continue engaging in these services once the baby is born. And now on the weakness side, some weaknesses that lie within this policy is capacity and bed availability. Bed availability. There are very limited hospital settings that actually implement this program. So while you may have immediate access, there may not be enough beds within that facility. Geographic disparity, like I mentioned, not every hospital is implementing this program. Therefore, if you are living somewhere where your hospital doesn't, that could create barriers to treatment and cause further complications. Post discharge continuity, because this is a hospital setting, sometimes the connection with outpatient services can be scarce, or there's low probability of follow through from the client and limited resources to make sure that client is continuing with receiving services. A narrow scope, their focus is mainly on SUD treatment, so there may not be additional resources provided to the client to help with any underlying issues that may exist and contributing to their substance use. Okay, now we focus on the therapist. What impact does the therapist have on this policy, or vice versa, right? So first we have referral and assessment. As a counselor or an ACDPT, you are often the one performing the initial assessment. And because this WAC exists, if you identify a pregnant client who is medically unstable due to use of substance, drug, or alcohol, you have a direct legal framework to advocate for their immediate admission into the program. And you have the ability to refer them to a state mandated program. The policy allows the medical team to focus on the physical withdrawal management, fetal monitoring, which allows the therapist to focus on the psychological. And according to NIDA, pregnant women often feel intense guilt and stigma related trauma. Because the WAC handles the medical crisis, you can focus on the motivational interviewing and helping the client navigate emotional weight of their pregnancy, while also uncovering the deep rooted cause for addiction and continued use, which can often get left behind or placed on the back burner when your focus is on just SUD treatment. Now I'd like to focus on caring for marginalized communities. And this is important because we know that our marginalized communities are often faced with less resources than their counterparts, or more judgment based on their identities. And so it is important that we acknowledge how this policy impacts them. And so I want to focus on the protection. So it protects our low income clients by ensuring that Apple Health covers this high intensity care. It also prevents patient dumping, where hospitals might otherwise try to refer a difficult or uninsured pregnant patient somewhere else, or elsewhere. Some vulnerabilities are the fear of surveillance. As we know, people of color, those in marginalized communities, are often faced with more intense legal consequences. They're often more monitored than their counterparts. And so, even getting assessment could increase anxiety, nervousness, fear for their ability to go through with treatment, or fearing risk of losing their children, which brings us to the next vulnerability, is risk of issues with CPS. In my experience, like, many of my clients have been involved with CPS, and so that causes them to kind of adapt this treatment smart mentality, where they say just enough, or they say very little to avoid any run-ins with CPS. And on the other hand, this causes ineffective treatment. Like, if the client or the therapist isn't fully aware of what's going on, or things on the underlying issues, we can't effectively address the overall picture. And so it is important that the therapist is 100% transparent with the client. They are expected to explain policies, medical benefits, while also helping the client understand their rights and the reality of mandatory reporting in a transparent and trauma informed way. So, we offer and encourage counseling while letting the client, empowering the client to make this decision themselves due to whatever historical events have happened, and we want to be mindful of those things. As a therapist, advocating for clients is essential and crucial to effective care. Um, the 2023 PCAP final report proves that long term home based advocacy is what actually keeps families together. And so, as a therapist, some ways that I think is important we should be advocating for our clients based on this policy is dyadic care. So this means that the parent and baby stay together during withdrawal treatment, or once the baby is born, and allowing them to bond while still receiving treatment is essential, and way more therapeutic than separating them. We also want to make sure that collaborative transitional planning and execution is happening. We don't want to just give the client a phone number and let them leave the SUPP program. We want to call the provider with the client, and ensure that the discharge plan comes with a mental health appointment within 48 hours, so that nothing is missed and everything is smooth once the client leaves. And some examples of alternative care, or ways that we could kind of improve or change this up a little bit, is by proposing extending the 26-day limit or increasing funding for parent child assistance programs to follow the client for 3 years post delivery. This will allow for a way more smoother transition into the community, as well as support and following through while navigating child childbirth, postpartum, etc. Additionally, I think it's important that the SUPP program and services are extended to residential treatment centers, as keeping it in the hospital setting can create barriers to those who fear hospitals or who don't have access to a hospital, or whatever reason. I think that just allowing this program to be placed in more areas will be helpful. And to truly understand Washington's SUPP program, it helps to look at how other states handle the same issue. As every state has a different philosophy when it comes to addressing pregnancy and substance use at the same time. Some states will focus on a more restorative approach, and some states will focus on a more punitive approach. So today I chose to focus on California and Oregon, and so I have a couple of policies here that we'll go over. First, let's look at California. So, California Penal Code 1116513 states that a positive toxicology screen at the time of delivery is not sufficient for filing a child abuse or neglect report. This policy is about making sure that clients aren't afraid to go to the hospital in the first place, so that they can get the care that they need. We also have California Health and Safety Code 123605, which focuses on assessing risk and creating safety plans for baby and family rather than punitive approach. So we're doing the harm reduction route, seeing what the client needs and opening up space to create a plan so that we can move towards healthy living. Let's see. We also have Ferguson versus City of Charleston. While a federal case, this ruling is a cornerstone of California's policy, stating that hospitals cannot drug test pregnant patients for law enforcement purposes without informed consent. And I think this is important because allowing this to happen could keep those who need the care away, further causing more complications and the never-ending cycle of addiction. And then we have Oregon. As we look at our neighbor to the south, Oregon uses a harm reduction model. And their guideline states that this administrative guideline focuses on meeting the client where they are and emphasizes harm reduction over immediate total abstinence. We also have the Oregon Revised Statute 43092. Providers must conduct a substance abuse risk assessment within the first trimester as early as possible and inform clients of the risk and drug alcohol abuse, recommend counseling, and report de-identified data to local health administrators. One of the coolest things Oregon does is a policy called rooming in. Even if a baby is born experiencing withdrawals, Oregon's policy encourages the hospital to keep the baby and the parent in the same room throughout treatment. They believe that the bond between parent and child is the best medicine for recovery. And for therapists in Oregon, the role is about long-term support. We aren't just looking at a 26-day hospital stay. They or working with the family in their home for months or years to ensure that they stay together. To conclude my presentation on WAC 182 533 0701, I want to highlight that while this program is a powerful tool, it is only as powerful as the providers navigating it. So they are the ones who have the opportunity to shift the mindset from it just being a medical stay into the start of the recovery journey. By understanding this policy, they are ensuring that the client gets the immediate safety they deserve while also providing the long term healing that they need to end the cycle of addiction. And this happens only by implementing a non judgmental approach, harm reduction, and making sure that client autonomy is maintained, because it only works when they want it to work. So, yeah, thank you for your time.